My name is Kai Tuorila. I'm the trade counsel at the embassy. And for the first, I would like to invite to say welcome remarks by His Excellency, our Finnish ambassador to Thailand, Mr. Jyri Järviaho, please.
Thank you very much, Kai, and warmly welcome everyone to this afternoon's seminar organized together with Finnish alumni. So we are extremely happy to have alumni in Thailand and participating actively in this way in our work and being our important contacts here in Thailand. Today we will discuss about AI in healthcare and well-being for aging societies, technology, and certainly AI. Artificial intelligence will have a major impact in our lives. AI possibilities in healthcare and well-being of people, and especially of aging societies, will be of great importance. Possibly a game changer in the future. Precision medicine, diagnostics excellence, virtual health assistants, and so forth. At the same time, also, I suppose it's important to take care of the possible ethical considerations that may lay behind algorithms or data privacy issues. Aging populations, both in Finland and in Thailand, are similar. Thailand actually is aging extremely fast, probably the fastest phase in Asia. Finland already is an aged society. And so we have many expert companies and experts on these issues in Finland, and we are very lucky to have today here two of our companies present, plus presentations from Finland, from our University of Eastern Finland. We know that AI and technology can help us with all these challenges. The possibilities from personalized medicine to a more efficient diagnostics and proactive disease prevention are there as we move forward. Let's embrace this transformative power of AI and work together to unlock all these future possibilities of healthier life for all of us. And now, let me just say that a couple of sentences in this was produced by AI. So that's the way we can utilize AI, of course. I wish everyone a very interesting seminar today. We'll learn more about AI and the possibilities, and of course from our experts from Finland and Thailand. So very extremely important to listen today what we have to say. Thank you so much everyone for coming.
Thank you very much. And I just checked the live streaming is also working very nicely, and we have quite a few people who have registered for live streaming as well. So next I will introduce our moderator. After that he will take over the proceedings. And because this is a Thai-Finnish alumni event, so our idea is to find a prominent expert Thai alumni who have been studying in Finland, and definitely in case of Dr. Atakon, who will be our moderator, the case is like that. His short bio was only 3-4 pages long, so I a little bit shortened it. So he got his first doctoral degree in Nottingham, England in year 2000. Then he continued his postdoctoral degree in Innsbruck, Austria, 2003. Another postdoctoral degree in Lappeenranta University in Finland, 2004. And not enough doctoral degrees yet, he pursued another Doctor of Science degree at Lappeenranta University between 2004 to 2007. And now he is a professor of Artificial Intelligence in Machine Learning and Deep Learning at the Department of Industrial Engineering at King Mongkut University of Technology at the northern Bangkok. So, Dr. Atakon, please.
Thank you very much. Uh, Thank you very much, His Excellency and Mr. Kai and everyone. It is my honor to come here and to talk a little bit of AI. The technology of AI in the past, it was called expert system. And then approximately 10 years ago, it was called artificial intelligence, which is a kind of mathematics. And then approximately 5 years ago, the name is a little changed to machine learning. And now, and the next probably 5 years or 10 years, it would call deep learning. There are some different. First, AI is a mathematics. Inside AI, there are some other mathematics like artificial neural network or some other mathematics. Now, the application of mathematics is mathematics. So, people think AI can be used as a forecasting model. Forecast what? For example, weather. Forecast skin. Forecast age. Forecast disease. Forecast symptoms of aging people. Now, when we are talking about forecasting, it comes with error. Normally, people will not say anything about error, but because computer is better and better and better, that means the error is getting lower and lower, and that's why the application of AI is in machine learning, which is the advantage of AI mathematics. The most important point of AI mathematics is it has an learning ability. Learning ability is very important because normally mathematics cannot learn, but the AI mathematics can learn, and because it can learn, which means if you have larger and larger database, it will learn a lot, and the error is getting lower and lower after the learning is bigger and bigger. Okay, now today we are talking about the healthcare and well-being. We have many professors and experts from Finland. I asked two of the most well-known from Finland about healthcare and well-being, and also the other professor in Chulalongkorn University. And I think first I would like to introduce the keynote speaker first. Okay. I thought you were the first speaker. Sorry about that. Okay, first, Dr. Petri Hotinen. The other one first. Okay. The other one, Professor Jane. Yes. Professor Jane Matikainen, health economist from the University of Eastern Finland.
Thank you and good morning from Finland. First question, can you hear me?
Oh, yes.
Very good. It's my pleasure to start this seminar, even if I didn't know that I'm the first one, but that's not the problem. Just a moment, I will share my screen. Yes, and then the presentation. And now I think that you can see my presentation. So, good morning, oh no, good afternoon there. Here in Finland it's morning, still morning, but there it's already afternoon. So, my name is Janne Martikainen. I'm a health economist by training. And at the moment, I'm a professor of pharmacoeconomics here at the University of Eastern Finland. And I'm also a head of university's House of Effectiveness. And House of Effectiveness is a network of effectiveness researchers who are interested about effectiveness, cost effectiveness of healthcare system, and how we are able to improve the cost effectiveness and effectiveness of our healthcare services. So that's my background, and now I promise to talk about how we could model treatment pathways as a digital twin. And of course, there is two questions: what I mean by treatment pathways, and what do I mean by digital twin? So let's start a bit about the treatment pathways. So idea, what I'm going to show you in this presentation is that we can consider those services as a patient journey. I mean that how the patients use the services and what kind of treatment pathways they go. And in this presentation, I'm going to use a type 2 diabetes as an example, because as we heard in the previous presentation or introduction, the aging is increasing the prevalence of type 2 diabetes, and like in Thailand, also in Finland, we have a lot of the aging is very rapid, which means also that we are going to see more and more, for example, cardiometabolic diseases in Finland, and one of them is of course the type 2 diabetes, which again is related to, for example, the increasing risk of cardiovascular diseases, and also nowadays we know that type 2 diabetes also is associated with the dementia, which is heavily related to, of course, the aging of the population. And then another topic what I'm going to talk about is digital twin. What do we mean by digital twin, and that kind of how we could apply digital twin approach in a case of treatment pathways and in a case of type 2 diabetes. I need to be honest in this case, so we don't have ready digital twin for treatment pathways for in the case of type 2 diabetes, but I'm showing the journey, what we have done so far, and what kind of plans we have in the future to combine all of these things as a one system to handle and make a predictions based on the digital twin approach in the case of treatment pathways. So that's the background of my presentation. So let's start a bit talk about a theoretical background. So this is the equation of value framework, how we are able to produce future value in healthcare. And to get the better idea, you can consider this future value as a patient value as a patient perspective, how we are able to improve health outcomes in a case of health, for example, type 2 diabetes. Or you can consider future value as economic value or profit. But it depends, of course, the system, what kind of healthcare system we have. But anyway, how we define the future value, the idea of background is the same. First of all, we need data. We need to be able to have platforms to collect the data. We need to have systems to combine the data and connect the different kind of data streams. Nowadays, we have lots of data. For example, what we are operating in Finland, we are using, for example, electronic health records data, laboratory data, also genomic data to predict the risks of diseases, for example. But now even more and more different kind of wearables, for example, or Internet of Things are available. And all of that data could be basically combined. And when we have that kind of very rich data sets, that could be improve also the innovation. And we think in this future value framework that this innovation could be powered by the data, which is, of course, that's the way we do things nowadays. But when we consider what is the innovation, I would say that we need to consider different kind of outcomes, times personalization to produce new innovation with the new real-world data. And what I mean by outcomes, I mean that we need to have a very broad understanding about the outcomes, what the healthcare system could provide for the people, for the physicians, for the payers, owners, and also the policymakers. We need to have a more, let's say, holistic approach about the outcomes. And one way to improve, I would say, innovation and also the effectiveness of healthcare system is the personalization. How we are able to improve the precision of those interventions that we are providing. And in this, my case, I'm very interested about the prevention. I mean, primary and secondary prevention of type 2 diabetes and other cardiometabolic diseases. And to be able to do that, we need predictive approaches. We need proactive approaches that could give us an understanding that what could be the future of the patients with the different kind of risk profiles if we are able to do proactive interventions to prevent, for example, disease progression and related outcomes. So that's my way, how I think and how I want to use real-world data with AI and machine learning approaches to produce innovations based on the outcomes inside and also the personalization. So this is the framework for my presentation. So let's talk about a bit about the digital twin approach. What do I mean in this case, digital twins? Because there's lots of different kind of explanations or definitions for the digital twin. So I think it's good to also define what do I mean in this case by digital twin. And if I very simplify the definition of digital twins, so basically they are just a digital replica of the object or a system. And in this perspective, I also define the treatment pathways. So we could consider digital twin in my case as a digital replica of treatment pathways. And what does it mean? What does it provide when we are aiming to build digital replica of treatment pathways in the case of type 2 diabetes? So basically it could give us a very interesting possibilities to learning and discovering new knowledge and new hypothesis generation and testing. So for example, if we are able to see based on our digital twin that there are very severe bottlenecks, for example, in the treatment pathways, so then we are able to consider that what if we change the service provision in this case a bit, what could be happen? What are the outcomes? What are the costs if we change our services? Or, for example, what if we start to monitor patients by using the digital tools rather than always have a meeting, face-to-face meeting at the hospital? How much that would impact the costs and the health outcomes and that kind of things. So in the future, I can see that digital twins could provide us a really nice possibilities, that kind of in silico experiments and comparisons, which means that we are able to make the predictions before we actually implement different kind of policies or new treatments in the system. And that could be a way improve significantly our system based on in terms of effectiveness and cost effectiveness. And I really believe that in the future, the digital twin technology could help us to make a virtual simulations, like I already mentioned, enhance the patient care, also the optimized clinical operations by analyzing the workflows and resource allocations. What are the optimal resource allocation and workflows that improve the effectiveness and cost effectiveness of our services? And of course, when we are talking about the prevention, I think that digital twin approach could help us in a personalization of treatment planning. So we get better understanding that different kind of profiles are associated, different kind of health outcomes and also the cost outcomes. And when we are able to have more personalized approaches, that could help us to have a more interventions where the patients are also engaged. And when we are talking about prevention, engagement is very significant thing impacting on the outcomes and also of course the costs. And one thing that there are already quite many high number of solutions is the early detection of health risks, for example, and proactive preventive interventions, like I mentioned. So this proactive approach is one of the most significant advantage of digital twin approach or technology, I think. So let's go talk about the type 2 diabetes as an example. You might already know that type 2 diabetes is very common conditions, and at least, for example, in Finland, it's very high number of people with diabetes, and it's of course it causes a sugar level go too high, and one of the main target of type 2 diabetes treatment is to achieve and maintain good treatment balance, meaning in terms of sugar levels, to avoid complications and premature deaths, because these high sugar levels are associated very many complications. So, for example, related to macrovascular and macrovascular complications. So, for example, cardiovascular or acute MIE, and also the strokes and that kind of complications, which are very, of course, bad thing for the patients, and they are also very costly for the system. So that's why there is a real clear aim to avoid of those complications. And in a case of type 2 diabetes, at the moment, the challenge is that we understand that there is a real need for individual tailoring of treatments because of the heterogeneity of type 2 diabetes patients. But still, we have just national guidelines and which are more or less standardized, which means that we just have this one size fits for all approach, and it's very clear that it's not the optimal for everyone. So in many cases, when we are following the guidelines, we do too much of monitoring related, for example, the risk of complications, especially in cases when there are any problems with the sugar levels. But still, it's required by the guidelines that you need to do that for your patients. So what we have done, so we have used this kind of similarity analysis to find patients with the similar care needs and treatment outcomes. And we have also considered that when we find this kind of similar patients, what kind of budget outcomes or costs they have, what kind of clinical outcomes they have. And this is has been our first steps in the journey towards to the digital twin. And now I'm going to show you some findings, what I have managed to, my group, we have managed to find related to type 2 diabetes. So this is the first example where we applied electronic health record data enriched with spatial data. So it means the spatial data means that we were able to combine that kind of postal code level data from the national registries, and also combined with the patient level data from the electronic health records. And we combined this real world data set with the AI and ML approaches and methods to find similar type of patient groups. So we use this kind of similarity analysis to define. Here on the right hand side, you can see the curves which are presenting the sugar levels over time. So in this case, we had a 6 years data set to follow what kind of trajectories of sugar levels we can see among the patients with type 2 diabetes. And you can see the most, maybe I can put the highlighter. pointer option slicer here. So here we can see big portion of patients that do not have any particular challenges with the sugar levels. So the aim of the goal of the HbA1c, HbA1c is at 53, and if it's below of that threshold, the sugar levels are usually considered that there are no problem. But there are two other subgroups of patients that they really have challenges with their sugar levels. And that's why we wanted to build a prediction model that predicts these, that what is the probability of different trajectory memberships. And we used different so we used AI and ML approaches and also different kind of predictor sets. So first we built the model with the clinical predictors and see that, okay, the previous year HbA1c value is the most powerful predictor of the membership of these trajectories in the future. We also added that what would be that if we combine the clinical predictors with the treatment-specific information, and here you can see what were the most powerful predictors for those predicting those memberships here. And we also added those spatial level socioeconomic factors, and there are actually some spatial level socioeconomic factors that are associated with these memberships. And that was actually a very interesting finding. But basically, if we consider the clinical practice, these are the most important predictors that predict what is going to be the future trajectory in the future in different kind of patient, for the different kind of patient profiles. So this was the starting point. And we also, another study where we studied a similar kind of approach. In this case, we have a patient with incident, just diagnosed type 2 diabetes, and we started to follow up that what could be happen to these patients if we use the similarity analysis. So we combined, once again, we use the similarities, and based on those similarities of patients, we make the groups that and group based on those trajectories for those subgroups. And we also studied that how these different kind of trajectories of HbA1c level over the 7 years, how they are associated with the medication use. So how the physician react the level of sugar levels and HbA1c levels, and how they try to intensify the treatments. So we know those information, we have information about those associations. We also estimated that what is the association between the risk of complications and these trajectories, and also the risk of death. So how different kind of sugar level trajectories over time are associated with the risk of death. And all of these, once again, give us a possibility to us to go a step forward to in the development of digital twin. So here you can see the third example. So we are also very keen on about this cost side. And one of the example is here, where we used University of Kuopio, University Hospital of Kuopio data to develop that kind of a prediction model to predict the individualized cost of treatment. And usually it goes that way, that patient goes to the hospital and he or she has been treated over there. And after the around 4 months, we know that how much the patient costs. But in this case, we wanted to be proactive and build that kind of prediction model that give us a possibility to make a prediction of costs already when the patient comes to hospital. And this comes, this is not used for the prediction of individual patients as such, but the aim of this cost calculator or predictor is to build and support the treatment planning. So what kind of treatment pathways we should have different kind of patient subgroups, and what are the expected costs. And that was the idea. But once again, this was development that could be a part of the more holistic digital twin approach in the near future, I hope. And here you can see one of our works where we also combine and make the predictions about the individualized treatment monitoring costs in the case of type 2 diabetes. So the idea behind of this study was that we have a very specific information about where the patients live and how they travel to hospitals and health centers, and based on the data where we have information about the roads, road maps, and where they live, how they are able to move from home to hospital, and that kind of information. We make that kind of map-based predictions that what could be happened if we start to use digital monitoring of disease rather than that kind of face-to-face meetings in a hospital. And in the case in this particular case, we saw that the monitoring cost per patients are around 280 euros per year per patient. But if we start to use digital monitoring of same patients, where they actually do the sugar level monitoring remotely, we can see that there is a high significant savings potential based on that approach. So this is once again, it's going to be a part of the more holistic approach when we are there and able to bring all of this information together by using the digital twin approach. And this is just an example about how we are also be able to predict does some treatment or digital health app, for example, works for the patients. So we built for the prevention of type 2 diabetes that kind of BitHabit applications, which was used for intervention in terms of lifestyle change. And we collected app log data when the patient used this app, and we also once again used the similarity analysis to predict what kind of user habits and what is the level of user engagement related to this digital health app. And based on those similarity trajectories, we estimated that who are those patients and how the user activity and user engagement is associated with the changes in risk factors, for example, in BMI. And based on that, we made updated this model that we are now more and more understanding about who are those patients that we should provide this BitHabit type application for the use to see changes in risk factors. So this is just an example how we have also applied the similarity approach to define those patient subgroups. So this was my presentation. I'd like to thank you. And like I already told you, we are not yet there. We do not have a digital twin yet, but we are building those blocks that are needed for the development of digital twin in the case of type 2 diabetes. Thank you very much.
Thank you very much, Professor. Do we have any question from the floor? Yes.
Hi, my name is Arashi. So just a quick question. How do you perhaps see the use of the data from CGMs to play a role? Sorry about that. How would you predict perhaps the use of data from CGMs, the continuous glucose monitors, to see how over time patients A1C perhaps deteriorates or hopefully improves, but or predict the ability of cognition to either improve or decrease over time?
Yeah, thank you. Very interesting question. We are actually doing that in a case of type 1 diabetes at the moment. So we have collected the data from those patients who are using those glucose monitoring. And we have actually already published some of those findings. And it seems that actually it has benefits in terms of more better treatment balance. And what we are doing at the moment, we are actually make long-term predictions in terms of health outcomes and clinical outcomes, but also in terms of cost effectiveness. So those results will be available, hopefully during this next spring. So then we know more about what is the situation, what is the clinical and health economic value of those devices in a case of in the treatment of type 1 diabetes at least.
Perfect, thank you.
Hopefully that answered to your question.
It did, thank you. Just a very quick follow-up question on that. Have you thought of perhaps monitoring or at least labeling with the data available from CGM with the nutritional value? Because I would pretty much put my money on the bank that it would be associated with a high carb diet every time you would see a spike in insulin.
Yeah, we need to consider that. But good point. Thank you for that.
Well, thank you. It's something to look forward to.
Yeah, thanks.
Thank you.
Hi, I'm Tammy. Just a small question with how diverse was the data set that you used to prove or find a solution? How diverse was it?
So we have a lot of people. So we have all of those information about the primary, secondary care healthcare use, procedures, operations, laboratory tests, which are usually done as a part of the routine, clinical practice, and some cases we are also, or basically it's possible, but we haven't done that. But actually partly. So we are also able to include prescriptions. So we know the prescriptions, what kind of treatment they should have. But we also have combined information for pharmacies. So what they have actually using. So they have to go to the pharmacy and actually buy the treatment and that kind of thing. So the one good thing in Finland at the moment is that we have this secondary use of health data legislation, and it gives us a possibility to combine actually all of the different kind of data which is available from registries in Finland. And one advantage in Finnish system is that everyone in Finland, we have this unique number, personal number, which give us a possibility to combine different kind of data sets or registered data based on that your unique personal number. So I would say that it's going to be more and more, at least deep data in that sense. So we have a lot of information, and even I know that there are some pilot studies where they combine that kind of loyalty card information from the supermarkets and that kind of things, which gives us, of course, a very interesting point of view, what we eat, how we behave, and how that impacts our health, and of course the use of healthcare services.
Thank you. And just as another little question with that, so how did you compare against this model with other models? The other models that available out there? How many % does it help compared to other
Do
models?
you mean?
Yeah. And
do you mean?
Yeah,
sorry.
Sorry. And what kind of metrics did you use for that, for comparing the accuracies and everything?
So when we are talking about models at the moment, we usually talk about that kind of patient or population level models where we are aiming to make the predictions at the population level. And what we are trying to do now is go more to the patient level data predictions and take into account more patient-specific features and make predictions based on that. I'm not aware, do we already have that kind of metrics to compare different kind of models in the case of digital twin and the case of when we want to combine digital twin approach in the case of treatment pathways. So probably we need to build that kind of metrics if we want to compare. So I know that there are that kind of challenge meetings where they compare these population level models and make the validation against different kind of models. But in a case of digital twin approach, I'm not aware that kind of development yet.
Thank you very much.
Thank you.
Do we have any more questions? I actually have many questions, but I will not ask because I am asking Dr. Petri Huhtinen to present during his preparation. I would like to thank you, Professor Jain, first. So next, Dr. Petri Huhtinen. He holds PhD in vitro diagnostic and MSc in biochemistry and BBA in information system science. He is currently the critical director of the company, and his critical view is in the core of company strategies, and I believe he is ready now, so please. Thank you.
Thank you, Doctor. Great pleasure to be here. Actually, Thailand has a special meaning to me since I was here 25 years ago celebrating my honeymoon as a newlywed young man together with my, at that time, young wife. She's unfortunately not with me this time, but maybe next week we can come together. Yes, so I will talk about artificial intelligence, fundus imaging in disease screening. Obviously, these terms may not be familiar to you all, but I will break the title in 3 parts and then have a brief introduction into the theme to follow. But before I go to the actual topic, I just want to tell you I come from a company called Optomed. It's a Finnish company, and we are the world leader in providing handheld fundus cameras and also different software solutions to go with it. And we also, as one of the part of our offering, we offer AI-based services together with the fundus imaging. So, artificial intelligence and fundus imaging screening in disease screening. So, this is fundus image. It's an image of the eye, and actually it is the back part of the eye. And if I take the pointer here, so the image on the background is taken from the back end of the eye. So that's what I talk about when I talk about fundus images or retinal images. So that's piece number 1 of the title. Then we go to the artificial intelligence, and Professor Attakon described AI in a similar manner. So artificial intelligence is a huge term. It includes many things. By the time being and by the development, people started to talk about machine learning and deep learning, which are actually subtypes of artificial intelligence. And in brief, we can teach computers to detect, for example, automobiles based on the different characteristics of the automobiles. So we give 1,000 images, and there are cars in some of them, and the computer, which is trained to do that, can tell us which of the images have cars in them or not. And then fundus imaging and AI, artificial intelligence, they are not actually very new things. This is a very busy slide, but if I underline 3 years here. So first fundus photograph was actually taken 1086. So that's like 140 years ago. Then the term artificial intelligence came 1950s, so 70 years after taking the first fundus image. And 2016, there was a first publication where deep learning was applied in the detection of diabetic eye disease, diabetic retinopathy. So some of these things are not very new, but there's a big hype about using AI together with fundus images to detect different disease. And then the third part of the title was about screening. I always want to remind the audience or people I talk with that screening is not diagnostics. Screening is something where you are looking for a subpopulation who have elevated risk of something. People typically know breast cancer screening, which is done in ladies at certain age, and whoever has elevated risk of breast cancer, then they will go for further examinations, and they are being diagnosed or not diagnosed. But screening is not diagnostic, so there's error, as Professor Atakon also mentioned. Error is involved in screening always, and that's good to keep in mind. There's a difference between screening and diagnostics, and screening is done to detect someone who has elevated risk for something. Okay, now let's look into the eyes. Obviously, since we are providing fundus cameras, we take pictures of eyes. Eye disease are important to us, and that's something we want to help to prevent. There are 4 big eye diseases which cause blindness, and 3 of them affect fundus. So 3 out of 4 we can detect with using these fundus images. And if they are not treated early enough, if they are not treated at all, they will lead to blindness at some point. Diabetic retinopathy is one of them. Today, globally, there are about 500 million people with diabetes. All of them may develop diabetic retinopathy, which is eye disease related to diabetes. And here's a picture of a vision of a person who has diabetic retinopathy. So there begins to be black spots in their vision, and then these spots get bigger and bigger if they are not treated, and in the end the person would go blind. So diabetic retinopathy is one of the disease causing blindness, and actually it's the most common disease causing blindness in working age population. Then we have age-related macular degeneration, AMD. This can affect any of us when we grow older. With AMD, the issue is that the region of sharp vision, so what you see in the middle of your vision, that becomes blurry. And if it's not treated, the blurriness gets worse and worse and worse, and in the end, you lose your eyesight. And then the third big one is glaucoma, where it's in a way kind of opposite compared to AMD. Instead of having issues with the sharp vision region, our eye vision becomes kind of like a tunnel, and the tunnel becomes darker and darker, and in the end you only see very little in the middle. And again, if nothing is done in time, it causes blindness. And then glaucoma and AMD, they can affect any of us when we grow older and older. Diabetic retinopathy obviously is linked with diabetes, but the fact that diabetes is so common, it's a huge global issue as well. So for these 3 diseases, in the old days, eye specialists were needed. Unfortunately, the number of people having issues with their eyesight is so high that there's not enough human resources to take care of them or examine these people. Therefore, there has been lots of research done to utilize AI in screening for this disease. And here I have a picture of healthy fundus or retina here, and then pictures of one with AMD, DR, or glaucoma. And as you can see, if you can see the images close enough, you can see that there are some changes here in the middle. There are also some changes here. And with glaucoma, the changes are in the optic nerve head, which is in the middle here. Obviously, human eye can also see these differences, but it is time-consuming, and of course there needs to be someone who's doing the job. In many of the countries, including Thailand, Finland, there are diabetic retinopathy screening programs where people are looking at these images day after day after day, trying to see the differences. And of course it takes time, people get tired. On Friday afternoon, my results would not maybe be as reliable as they would be on Monday morning when I come to the office after relaxing for the weekend. So we can train computers to detect these changes, and they have actually been trained already for many years ago, and as I mentioned earlier, 2016 was the first AI-based algorithm published to be used in diabetic retinopathy screening. And then in Europe, where we follow the CE regulatory environment, in April 23, so about half a year ago, in the European market, there were already about 10 different algorithms that were approved as a medical device to be used in diabetic retinopathy screening. So in Europe, a healthcare system could use, in theory, any of these as an aid in the diabetic retinopathy screening to save some of the human resources to do more demanding job than look for these small changes in the middle of this example image. This list was published in April. I know that today the list has at least 3 more names. So the options are getting greater and greater. There are more and more alternatives to pick from. So this was all about eyes. But our eyes are such a fascinating organ that they are not only for seeing. There's so much more behind the eyes. Of course, seeing is important, but we can do much more. And the reason for that is that actually, if you look at the kind of close-up of the part of the eye is an extension of our brain. So the optic nerve, which is visible in these fundus images, it's part of our brain, part of our central nervous system. And there's huge amount of capillaries in the fundus. So our cardiovascular system is actually very active in the back end of our eyes. Now, if we know these 2 facts, we know that the eye is part of the central nervous system, and there's lots of blood circulating in our retina. We could guess or make an assumption that one could see actually differences happening somewhere else in the brain or somewhere else in the cardiovascular system. The changes could maybe be seen in our retina. And this has been actually proven, I think, 25 years ago already, that if we just could take the fundus image, we can also look at the cardiovascular system, follow the changes, and we can see some of the neurological changes taking place in the eye. 25 years ago, it was not utilized a lot in the healthcare because the changes may be so minor, so small, that it's nearly impossible for a human eye to detect, at least in the bigger quantities. But now, with the computers developing, us being more able to teach the computers to learn, so us utilizing AI, we can now create algorithms that can actually detect neurological changes or cardiovascular changes with these same fundus images. And then I have made here a list of different algorithms that can be found from the scientific papers. So some of them are still kind of in the science mode, but many of them are already available. So if we go from head to toe, or at least from head to kidney, in the upper body, we can use the fundus images to look for early signs of stroke, or can estimate the risk for stroke. Papilledema, which is a sign of intracranial pressure, so there's too much pressure in the brain. It can be seen through the eye. And of course, if there's too much pressure in the brain, it can be lethal, so it can lead to death in the worst case. So there's an algorithm to be used to detect papilledema. And also Alzheimer's disease or mild cognitive impairments can be seen through the eyes. Going down from head to cardio, to the heart region, so there are several different algorithms looking for cardiovascular risk, stratification or prediction. So wouldn't it be nice to go and have a non-invasive eye image? So something which takes few seconds to capture the image and get a risk estimate for the future cardiovascular event. At least it would be more friendly for the patient or for the person being investigated, and probably also faster because you can get the result right away when you take the image, or within a minute, instead of having blood drawn, analyze that in a laboratory and returning the result. And then going down from heart to liver and kidney. Also certain liver disease and certain kidney disease can be seen using the fundus image. So eyes are not only for seeing, and not only eye disorders should be investigated using the fundus images, but we could use any of these. As said, I'm referring here to scientific papers, but some of these are already available in the real world, not only in the scientific articles or congresses. And now many of the algorithms that I'm referring here, what I mentioned with the eye disease, they are kind of giving you the status, but today the development of the algorithms is going more and more for the prediction. Instead of saying that what do you have today, you have diabetic eye disease, we can say that what you might have in 5 years, what's the risk of having diabetes in 5 years or 10 years? So kind of that's also changing from the current status to looking into the future. And I don't know, this is also in a way fascinating or then scary, I don't know, but people are saying that you can actually see your biological age from the fundus image. So I'm 52 or 3 years old, I take an image of my eye, and then the machine tells me if I've been living like a 53-year-old person, or is my eye older. If it's giving me a red alert, then I could exercise more, eat healthier to be on the green zone again. So I don't know if it's something I want to know, but that's also something people are developing and publishing in the papers. And as I said, it's not only science. There's also, I have one example. This is actually from New Zealand, company called Toku Eyes. They have two algorithms, BioAge, which tells you the biological age based on the fundus image. So it could be a motivator for lifestyle changes. If you get a yellow or red alert, it could be very rewarding to get a green sign if the AI tells you that, okay, your biological age is actually 3 years less than your calendar age. And then they are also working on so-called CLARE, which gives you a risk for cardiovascular events. And the BioAge is something they are already promoting commercially, for example, in Australia. And CLARE is something which US FDA was assessing, and they said that this could be such a game-changing tool that they took it on a so-called fast track or breakthrough device program with FDA, so that Toku Eyes from New Zealand can communicate with FDA very closely to get this algorithm into the US market so that it could be used in healthcare. So it's not only science anymore. There are, and this is only one company with 2 examples. There are some others. However, it's very new, so it's not something that are used on a daily basis anywhere yet. But it could be, and it's coming. Of course, coming from Optomed, I want to link Optomed into this big picture. With our handheld machines, we can take these images practically anywhere. So it takes a few seconds to capture an image, and we can send it, because of course it's digital image, we can send the image to a cloud portal which communicate with these different AI algorithms and returns the screening result on the camera screen. So one could actually, in this room, take images and have the screening result on the screen right away. It would tell you that, okay, there's an elevated risk of something, please go and see a doctor. So this is how it could be done in a cost-efficient way and also very accessible way. People do not always have time or money to go and see a specialist. Eye clinic might be 2 hours away. Even with Bangkok traffic, if it was only 1 kilometer away, it could take 3 hours on a bad time. But the idea of providing eye examinations, making it more accessible, affordable to all, and then combining different AI algorithms, it's very fascinating. It could be a cost saving and of course life saving action. It's not only Optomed who's saying this. This is a paper published in Nature, which is one of the top scientific papers, and these names are some of the key people working on deep learning and assessing the possibilities in deep learning. And here on the bottom of the page, they say that this could lead to a paradigm shift in care in which eye exams screen you for the presence of ocular and non-ocular disease, something currently limited for human physicians. So actually now they also claim, and many others, that why we should not stop looking at eye disease only, because we could do so much more. And with that said, I'm more than curious to hear your thoughts and questions about this all. Thank you.
Thank you very much. Do we have some question? Any question?
This is excellent. Have you thought of putting the device in like grocery stores? Where you and malls?
Yeah.
Have you thought of putting a device in grocery stores and malls where you have a lot of foot traffic?
Yeah. Of course we have. But we typically sell the devices to end users, so we don't provide such a service, but we'd be more than happy to work with someone who would provide that service. So I think, especially here in Asia, we have been talking a lot in Singapore, in Thailand, in some of the other countries with very rich population, and maybe, as I said, the traffic can be such bad that it takes 2 hours to go 3 kilometers, 2 miles. So you'd prefer to go to a mall. And it would be doable. Of course, everything can be transferred using clouds and so forth. Of course, then we need to think about cybersecurity, its health data, but it's doable. But it takes someone to run the business. We have the tools. Are you interested?
I'm not that person, but I'm sure someone in this room may know someone who is.
Yeah.
Hold on.
Because glaucoma is a kind of disease that leads to progression, and when detected, this one should be
Late. Yeah, I think with screening and prevention, the key is to start screenings as early as possible and to look for mild signs. And of course, I know that people are recommended to have regular eye checks every 3 to 5 years after turning 40. Well, I'm about 40. I'm not having my eyes checked, but if I did, then there would be a record of my eyes, not only fundus image, but the eye pressure and so forth, and they would see the changes. But it is true that many times we do not go to see a specialist if we are feeling fine. And glaucoma, diabetic retinopathy, others, they start without causing any symptoms. And that's a real issue and key for screening and prevention. Sorry, there are a couple of questions in the back. if you shout, I'll listen carefully.
Hello. Hi. Great talk today. Thank you. I have questions about, I think the eye disease is clearly explained, right, with the retina image, right? But in terms of systemic disease, how the doctor in community, from your experience, perceive that or believe in this prediction model or the model to forecast, to predict the systemic disease from the eye?
That is a very good question. I would assume you have been thinking about that yourself a lot as well. Yes. Yeah. Of course, these are new things, and we know the healthcare system develops slowly. And if we think the use of AI, it's been used in different fields for decades already, but not a lot in primary care, for example. And this would certainly help a lot in primary care. And I think it requires a mindset change, and that change will take time, but in my opinion, it's happening. I've been working within this field about 5-6 years only, and I see things changing. There are more and more papers coming. Doctors are reading these papers. They get curious. So I think that we all just have to be patient. But the fact that there's not enough human resources to solve all these healthcare-related issues, there's not enough money in any government budget to solve these healthcare issues. We need to look for cost-efficient and efficient solutions, and I think AI fundus imaging would fall into that cost-efficient solution.
Thank you.
Yeah, and then there was another one on the back as well.
I got a quick question, and first of all, thank you for your session. My question is all about the concept of AI for screening. So, as I understand, when you use AI, you need to train the AI back. You need to feed some information to train the AI. When it's used with for example, the GP who is working in their local clinic for primary care for the screening. So, how can you train the AI? How can you detect it if misdiagnosed or not? So, for example, if you use the AI in the specialized hospital where you can use it with the specialist, so when it misdiagnosed, the specialist can train it back.
Yep. Well, first, it's just like you said, the AI needs to be trained. It's not very intelligent. You have to be more intelligent to train the computers to do what we want them to do. The medical devices, so something which is developed and approved for healthcare use, they have been trained and then in a way locked. So you don't keep developing them when you use them in clinical use. And of course, the training, for example, for diabetic retinopathy is fairly easy because there are public data sets available, and you can download the data sets and train your algorithm with these public data sets. And then, of course, you need to do validations in your own subpopulation. And this is actually very important because based on our experience, we have been testing many new for diabetic retinopathy, and I can claim that they typically work very well. But still, whenever you take a new tool into your healthcare system, you want to make sure that it works in your environment. So therefore, I think that the local validation with smaller data set is enough. And at that point, you are not training the algorithm anymore. It's locked for use because the authorities require certain performance, and the developer has to show that, okay, my algorithms is doing what we claim it to do. And of course, then you can continue developing, but then you have to kind of re-register the version 2, version 3, version 4 as you develop it further. But in clinical use, if you are using algorithms approved by authorities for medical use, you are typically not allowed to develop them on the fly.
Thank you.
Hi. Very interesting idea. I just wondering, like, okay, I used to work at Chilabon Hospital, where they developed like this kind of similar program, but not like through the eyes. What's the accuracy of it, or like what kind of metrics do you use for that one?
Yeah, so with screening, they typically report sensitivity and specificity.
Yeah.
So these are the what's the probability of getting the right answer. And in screening, there are always wrong answers. So there's no screening test which gives you always the right answer. That's called diagnostics. And even diagnostics can go wrong sometimes. But with the diabetic retinopathy algorithms, which that's the most, it's been the first one because the number of people with diabetes is so high. There are hundreds of algorithms available, and typically the algorithms have sensitivity, the good ones, 90 and above, 90%, and specificity maybe anything between 85 and 95%, depending on the algorithm. At the same time, the recommendations, international recommendations for human performance, so someone who's been trained to read the images, trained to analyze the images, the requirement is to have, well, in the mid-90s they said that at least 80% sensitivity, 80% specificity, whereas computers are doing 90-90. And now they are saying that 80% sensitivity, 95% specificity, because specificity has maybe bigger cost influence. So typically, when we talk with someone, they expect the AI to give you a perfect result. At the same time, we ask the human experts who are doing it on a day-to-day basis to have only 8 out of 10 performance. So people are expecting the computers to be much better.
Yeah, they do. That's quite a high specificity. Do you get a lot of false positive?
Yeah, so it varies a lot. Of course, these are recommendations, the international recommendations, 80 sensitivity, 95 specificity, and then different algorithms. They typically, how it goes, somebody develops the algorithm. Our company, we do not develop algorithms. We work with different developers. Someone develops the algorithm and publishes a paper. Our AI performed this and this in this study. And if you take that same algorithm to another population, studied in different population, let's say if somebody in Finland developed an algorithm, did it in Finland, and then they did another study, even in Sweden, our neighboring country, it would not be the same result. It would be very similar, but not the same. So you cannot repeat the exactly same result from time to time. Therefore, it's important to realize that what is required by the screening program, for example, and what's the typical performance, and then you start fine-tuning your program and tools you are using, if it's AI or if it's human graders.
Thank you. Do you think it can like detect something else as well? Since like so far it can from just the eyes, can detect so many like diseases and all that stuff. Yeah. But do you think in the future,
yeah,
per se?
So I'm not a medical doctor. I'm not an eye specialist. But so this is my personal opinion. So for me, it makes sense that eyes, you can see eye disease, and since eyes are part of the brain, you can see changes in the brain, so neurological disease, and since there's blood circulating, you can see cardiovascular events. So it makes sense that if it's part of your cardiovascular system, you can see the changes. But of course, then cardiovascular has some other effects. So kind of like what does it cause elsewhere in the body? So maybe with some good combined data, there will be something which is not understood today. But I think that there's a lot to do for all of us before we are managing eye disease, cardiovascular events, and some of the systemic disease linked to brain or cardiovascular system.
Thank you.
Okay, thank you. So the next, sorry.
Sorry, I have a question, Doctor. So this device at the moment, why do you think that? So I understand that in Southeast Asia, especially now we have more cardio or how do we say? Heart attack problem, and we are here to speak about this. How do we say? Let's say retina or eye device. So is there how do we say? What is the? Is there a population that here potentially in Southeast Asia that is going to be severely that it's needed?
For example, people with diabetes, they have elevated risk of cardiovascular events, and the numbers in diabetes statistics here are horrifying. They are horrifying in many parts of the world, but also Southeast Asia. I think it would be very helpful for anyone who's got diabetes to have their eyes examined regularly. I know that it's not happening. I know that the government of Thailand is working on it, but it takes a long time to have a comprehensive screening program that actually reaches everybody who has diabetes. So of course diabetic eye disease would be screened, but with these newer algorithms, then also they could look for cardiovascular risk, because it's a known fact that people with diabetes have elevated risk for cardiovascular events, for example.
All right, then my number 2 question will be, so for now, if we are developing this device, is it dedicated for now? Let's say this 5 years, it's going to be B2B, or it's directed to the hospital. Is there any possibility that later on it's going to be an application only? Because nowadays people only detected the heart problems by scanning on the iPhone.
Yeah. So there's lots of discussion about using mobile phones for taking a good fundus image. It's being used, but the image quality is very poor. So you can see some of the more dramatic changes. Sometimes that's too late from the vision perspective. So therefore, we started the company. I was not part of the team, but the company was founded in 2004. So we have been focusing on handheld devices for 20 years already. And actually, I have the device here, so I can show it to you. But the image quality is very similar to what you would get in a doctor's office or optics shop. But so far, there has not been any mobile phone-based devices that would give you good quality images of fundus. I know iPhone is perfect for taking pictures, but it's meant for selfies and sceneries rather than focusing in a small area in the back end of the eye. And of course, we are also developing various things with our company, but so far I have not seen a good mobile phone-based camera for fundus imaging. And therefore, I think the use of cloud-based services, having the devices in the malls, like was mentioned earlier, in the booths or other pharmacies, that would help a lot. They should be somewhere where people are moving so that they could stop by, have screening done, not diagnostic, but screening done, and then if there's anything with elevated risk, then it's up to the person to make the action and go and see a doctor. But I want to mention about this device. It's designed, developed in Finland, but it's made in Thailand. So we have outsourced the production to Fabrinet here in Bangkok. So you can also be proud of the devices. They are sold all over the world and made in Thailand.
Thank you very much. So next, we are going to have panel discussion. So I would like to invite First, Dr. Petri, could you please stay there? And then, what about Dr. Jain? Are you still there? Okay. And can I invite Mr. Kari Beckman, CEO of Bennett from Finland? May I also invite Dr. Ong, lecturer of computer engineering from Chulalongkorn University and alumni of University of Turku and Turku University of Applied Science. So first, I believe everyone have been received very good research about the application of artificial intelligence and some other things like the eyes, things like that. But first, may I invite Mr. Kari to talk a little bit more about your work at the company, and I believe you have a lot of information to share with us. Please.
Thank you, Dr. Anton. Thank you for having me here. I'm happy to be here, and I also will bring you another view on data. I highly appreciate the previous speakers showing very deep health-related data and AI and analytics regarding that data. What we do in our company is that we focus on the part that is quite often missing today, which means the functionality data of a person, like the activities of a daily living. What we mean with activities of daily living is like motion, how you move around in the apartment. It includes sleep habits, how you sleep, what kind of a quality of sleep there is. It includes the hygiene patterns, how are you taking care of your hygiene, showering, toilet visits, everything, even washing clothes. Food preparation, that's something that we do at our homes, and even using of different walking aids, for example. So when you think about these topics, this data is not actually collected at all in the same way as our health data. I would claim that all of us are using some kind of a watch or app or something to collect our health data. We have the blood pressure meters, and we have different devices that we collect the health data. My friends in health companies don't like when I say that you have the easy part, because you have a device that collects the data and you have it in a structured form. But when you come to activities, then there is no device to collect the data, because the questions are quite hard. They are, for example, that is the person able to prepare a warm meal? Is the person able to wash her whole body? And there is no device, one device, that could measure that and give structured data. So what we do is that we collect data from the person's apartment about her daily activities. We collect it with different devices and sensors and create the data models describing her activities. Daily values in themselves are not so important. We have all good and bad days, and we perform activities in different ways. But the trends here are interesting. What is happening in the long run? How is the activities changing? And the activities are quite often also revealing some medical issues or some early signs of some sicknesses or any other problems. So the functionality data is in our hearts, and it's really important to analyze that part, and it's quite often not analyzed at all. Probably I will leave the discussion about digital twins because we have a certain interest in that, and Dr. Janne was already explaining very nicely what digital twins are about, and if there is a possibility later, I will tell what our thoughts are regarding the activities of daily life and creating digital twins of that.
Thank you very much. I would like to ask Dr. Ung to explain something about your research at the university. Thank you.
All right. My name is Aung Pei. I'm currently a lecturer in International School of Engineering in Chulalongkorn University. So, even though I do not specialize in AI or ML, but I do specialize in our UX UI, user experience, user interface design, interaction design, right? So the AI applications have become very advanced, very complex. So the role of user experience has become like prominent, right? So how we will use AI applications and interface in a more user-friendly way, more more effective interaction style we can provide to our users when it comes to the elderly people, because I specialize in the information system for the elderly people, the aging care, right? So currently I'm teaching in our ISC in Chula in terms of like software engineering, information systems, but my research areas include designing user-friendly interfaces for elderly people when it comes to the healthcare information systems, AI applications, of course. Recently, we have designed a mobile application for the elderly people and also the caregivers to have effective communication. For example, in Thailand, in Asia, most of the elderly people, right, it is very common that like we live together in one big household. But most of the caregivers, right, they do like, full-time, in most cases. So in that kind of situation, how to provide effective care to our elders, right? So when you are working full-time, how we will make use of the technology to have an effective communication. So we design our mobile apps to kind of like bridge the gap between the elderly and the caregiver. It can be our family members, it can be the caregivers, it can be like, your healthcare professionals and so on, right? So there are like, two interfaces, one for the elderly side, the other one for the like caregiver side, right? So the elderly people, most of the cases, they are not so much familiar with the interfaces, like they are not very technology savvy, right? So we have to kind of like make sure like the interface design, the interaction design for the elderly people must be kind of like elderly friendly, right? But at the same time, for the caregiver, they may have more features and functionalities and make it kind of like effective and efficient. So this is kind of like one area that I emphasize, that AI is a part of it, even though not 100%. So we are trying to collect like more data, the patterns, right? The communication pattern, the emotional expressions, and also like, check conversation. So these are the things that we collect from the application. Then using the machine learning algorithm behind, we analyze and predict and kind of like create a personalized, for example, game. Yeah, social gaming is a part of it, right? We design like gaming for both elderly people and also the caregiver to improve their communication. And another one is intergenerational games. So sometimes caregivers can be grandchildren, right? So how to improve nowadays, like grandchildren and the grandparents, we have like, a communication gap, right? So how to improve the friendly communication, much closer communication between these two generations. We design like intergenerational games, which is kind of a simple but like, attractive games for both generations. So these are some of the research projects that we are currently working on. Yeah.
Thank you very much. Very interesting. So let me ask Professor Mattikainen a little bit more about what are the potential advantages of digital twin in healthcare. Can you elaborate more about the potential of digital twins?
Yeah, thank you. Very, very good question. So if we are talking about very holistic way, what we usually mean by the digital twin, in the case of clinical medicine, it's the potential, of course, it's huge. But I think it's most challenged area also when we are aiming to build whole body as a digital twin, or even in some organ as a digital twin. But of course, from my point of view, there is also huge potential, at least in the healthcare systems like in Finland, where we are struggling with the cost constraints and budget, limited budget, and we need to consider that what could be the best way to use those limited resources to obtain maximum amount of health benefits for the patients. And in that sense, like I mentioned as a part of my presentation, I think that digital twin approach could provide a very nice way to plan and make plans and in silico experiments to get the understanding about, for example, that what could be the effectiveness and cost effectiveness consequences if we decide to use the optimate solutions for risk screening, for example, among the patients with the elevated risk of type 2 diabetes or that kind of things. So in that sense, I see digital twin in very promising approach as a part of planning the healthcare services. And it's a bit different approach what we have usually used when we are talking about digital twin. I mean that we are usually trying to develop that digital twin of human body and that kind of things. So, but otherwise we also have a digital twin for factories and that kind of thing. So this is somewhere in the middle. We need to understand the risk factors, how they impact on, for example, daily living of people, how the daily living of people and the level of that is impacting the need of healthcare resource use or social care use and that kind of thing. So I think that digital twin will provide that kind of holistic framework to get better understanding how things are associated with each others and how these changes predict outcomes in long term. Maybe that's one what I see that it's one of the biggest advantage.
Okay, thank you. May I ask Mr. Kari again? I believe you have something more to explain about digital twin.
Yes. If you think about care in general, it's provided either as home care or in a nursing or care home. And if we think of home care, the situation is that the nurses actually don't know so much about the clients. They do their visits, they are often quite short, there is many things to do, there's not much time for discussion. There is a discussion, but there is a lot of things in the elderly's lives that are not going to be revealed in that discussion. In general, you could say that home care is not yet digitalized. It's based on observations that nurses do about the clients, and they make their own subjective decisions how to treat the client or the patients. I think that in home care, for example, by being able to collect the data about the elderly's lives and even to create not so detailed digital twins as we can understand that is possible already to do on the health data side, but still being able to create at least some kind of digital twins will give the possibility to understand that which interventions have a positive effect on the clients. And we can profile these clients, and maybe quite quickly we could actually start prescribing the best possible interventions for a certain profile group. And this might happen quite quickly. We are, of course, helping our customers in home care and nursing homes to increase the care efficiency of the nurses. But at the same time, of course, the data is collected all the time. And it won't take a long time that we, for example, as one player, will have tens of thousands of elderly data, years of elderly data collected every year. So the data, the amount of data will increase really rapidly. And I assume that there will be other ones also collecting the same data. So there is no data at the moment, you could say, and quite quickly we might have a very big amount of data that we can use and use the machine learning models and all kinds of analytical models to create an understanding of the life of the elderlies. And it might be, there is a huge potential now to really move from observation-based processes in care to fully digitalized care processes. As a disclaimer, I have to say that, of course, the human touch is such that we all want to have in our care. So everything that I say will include also then that there is a nurse taking care of us all, but it could be much more efficient. And when we have a global problem of not having enough of caregivers, the only way to solve the problem is to digitalize, to use the data in a better way in this business. And I think that collecting the data in a structured form, analyzing it in all the ways that we can, creating the digital twins to understand what would be the most effective treatments for these elderlies will give us the opportunity to take care of the elderlies. Because if we don't do it the way we do now, it's not going to solve the problem.
Thank you, very good. Let me ask Dr. Petri. I believe everyone knows that AI, machine learning, and deep learning are getting better and better in terms of analysis and mathematical model. Could you please foresee some direction in healthcare, particularly at your critical provider of your machine?
So how to best utilize AI?
Yes, for the future.
Yeah, I think, as I already mentioned, the number of people with diabetes is so huge that we cannot manage and treat the disease well enough. There are 500 million people with diabetes globally. They all should have their eyes screened once in 2 years. Maybe some countries once a year, in some countries 1 in 3 years, but let's say regularly. And at the same time, there are about 250,000 ophthalmologists, so eye doctors. And there are lots of other eye issues, not only diabetic eye disease, that they have to treat. So there's not enough of expertise in this world to treat and manage only this one disease, diabetic retinopathy, causing issues and causing blindness with people with diabetes. So we need more resources. We can train people. Can we train enough of them? I don't think so. Of course, it should not cost more. It should be less costly. I think utilizing AI in the right way, we could also reduce the cost and then make it not only more efficient by providing more resources, but also more cost efficient by reducing the overall cost. We could find the people with elevated risk of diabetic retinopathy or some other disease earlier, and treating them would be less costly if we find them earlier. So there, I think the proper way of the use of AI would improve the clinical outcomes, it would improve the quality of life, it would lessen the costs related to healthcare, to give you an example.
Thank you. So I think we should ask the audience, do you have some questions? We have our panelists here. Yes, the microphone.
Can I talk about
Thank you. Okay. I just asked about how the trend or the technology is near to be the personalized. That I think is very good trend on this time, because at the long time until now, almost we take care on the whole picture of the public. So I think that at this time many technology is more nearly to be the personalized. So if the market is close to be the personalized by the record, something like that, or the elderly care or something like that, we can have some the good to respond or the answer of the need or demand of the person. Maybe I ask for how is possible
Which
digital
one?
twin and
Which professor do you want to ask?
sorry for the doctor on the screen.
Okay.
Yeah, so the question was, because sorry I didn't hear all of your questions, so apologize that, but the question related to personalization. And I think the personalization is one answer when we are struggling with the costs. I mean that it's a way to optimize the expected outcomes and the resources that we use to provide the services. And in that sense, to be able to, as I mentioned as a part of my presentation, when I mentioned that general value, future value equation is that first of all, we need quality data. And when we have access to quality data, it provides us the way, let's say data-driven way to build innovations. And to be able to build innovations, I think that we need personalization, as I mentioned, as a part of that equation. So data is a huge possibility for us to build more personalized interventions. Like Kari Backman mentioned, that in the case of elderly treatment or services, they are collecting data to get better understanding what kind of interventions are effective and cost-effective for elderly persons living at their own home. And it's clear that there's a huge heterogeneity because of background, the background diseases, what is the level of the activity of daily living and that kind of things. And all of those things need to be considered when thinking about what is the most effective way to provide services of elderly person living at their own home. So yeah, so personalization is the way to go, but to be able to do that, we need more data. And then, like in the case of Optomed, we also, it's a way to predict risks, and it could be very interesting to see in the future, because as we all know, we are struggling with these aging populations, that we find very easy way to estimate and risks, make a risk screening and estimate the risks, for example, stroke or Alzheimer's disease, which is very interesting approach, how we are able to find those who are elevated risk of dementia and Alzheimer's disease. And if we could do that just by taking a photo, it could be very interesting to see that what is the accuracy of that kind of risk screening. And maybe that's the way to go to provide lifestyle and other kind of intervention for those persons with elevated risk of Alzheimer's disease. Hopefully I managed to answer to your question.
Thank you.
Yes. Your way. Yes.
Thank you. So my question is specific to Kari. Obviously, we've discussed about how ADLs and IADLs are not currently structurally measured and how you would like to do that moving forward. But how can you effectively do that in the age where we're all technology dependent? We have smartphones, we have smart homes, and we're moving in that direction, right? And I believe there's LISA in the EU where you have these special sensor mats Lights are automatically turned on for elderly. You have special sensor and pressure gauging mattresses and whatnot. So how can you effectively measure? Of course, you can measure gait, right? But what about the other aspects? Did I just forget to turn on or off my lights, or am I just heavily dependent on technology and a little bit lazy maybe to not turn it on myself and rely on Alexa to do it for me?
Good question. I would say that when we talk about elderlies, we can't say that the capability of using technology would be an age question, because it's not, of course, as we all know. But I think that elderlies are kind of paving the way for us also that are not so old yet, because there's no way of collecting data continuously by requesting the elderlies, for example, to collect the data by keying in some app or using some devices or even clothes that would collect the data. So the ground thinking in our way is that the person should live their lives as they live, and the environment would be equipped in a way that it can then collect all the data that we need. And you shouldn't ever be bored by the technology and remember to put on something or turn off something. And we are heading there, of course. At the moment, we are placing sensors in the apartments because the apartments are not smart enough to tell all the data that we want. Very soon, the home appliances are, of course, getting IoT based, so we will get data from the fridge and coffee machines and stuff. The apartments are themselves getting a bit smarter so that we'll get more and more data. So I hope that someday we don't have to place any sensors, we just get the data from the apartments. Another thing that we are having a small study on, which is quite interesting in my opinion, is that could, for example, the apartments which are, or our homes are quite passive at the moment. We just live in them. and the apartments are actually not helping to keep up our health or our well-being. But there are, of course, possibilities, because the home automation, the building automation, they are also developed very rapidly at the moment. And it will be quite interesting to see, could we, for example, with the help of technology, help people with memory disorders still live at home by getting some hints of forgotten breakfasts or forgotten showerings or stuff like that. Just to give the hints, and we might be even able to live longer in our apartments. One thing that I want to mention here also is that it's maybe more a question of ethics then. Do we really want to be monitored? Is the first question, of course, for everyone. And most of us say that yes, if the benefits are bigger than the negative parts. But then there are questions which I would like to bring up. One, for example, when we collect the data and we run analysis on that, we can see trends that are implying some problems, maybe even some hints of some diseases. But the elderly or the person herself might say that, please don't tell me if you notice some memory problems, for example. Please don't tell me. And then we don't do it. For the other clients, we do. So what do we as a company do? Because we can see it from the data. Should we tell him anyway, or should we not? And it's a question that we struggle with a lot, because we see things and maybe the persons don't want to know about it. It's like sitting on the beach with a lifeline and asking that, should we throw it or should we not? And we don't have yet the answer, but of course we always live according to the client's requests, so we do what they want. But the ethics is really, really an important issue in this context also when we discuss the AI and usage of it.
Some more questions?
I might not have answered your question, but I used the time for something else.
Or otherwise, your answer is very, very good. We can have more questions. Oh, no questions. That means all of your answers are extremely good. So I believe if we do not have any more questions, then may I ask? Okay. So I would like to invite each of you to give us some conclusion of your research or activities or anything that you would like to express, beginning from the professor from Finland.
Thank you. If I summarize my thoughts is that our research, what we could provide, I mean, when we are talking about effectiveness research, particularly related to this applying to AI and ML, is that we probably want to add an additional layer in these solutions, for example, provided by Optomed and Benete, that we want to see that what are the real benefits of using this kind of AI and ML solutions, what are the outcomes, what are the expected cost consequences and that kind of things. And in terms of research, what we are aiming to do, we are aiming to build, like I mentioned, this digital twin approach for treatment pathways to support our healthcare service providers and planners to build even better and more cost-effective services for our citizens in Finland and of course other parts of the world. And this is the way what we are doing now and in the near future to be able to provide and build that kind of digital twins that are not patient-specific, but not totally population-specific, but something between that. So we are keen on to provide solution for subgroup and similar type of patients. That's my message to you. So that's what we are planning to do in Finland and of course in other parts of the world. Thank you.
Thank you very much.
I think that AI should be seen as a tool to provide better prevention in healthcare. It should be seen as a resource that we actually don't have in a global scale. Other fields of life have been using AI for decades, and I think healthcare sector should be brave enough to use efficient AI-based tools as well.
Thank you.
Okay, so I would like to conclude our conversation focusing more towards our target user group, right? So we are talking about the elderly groups, right? So they are very vulnerable. They have like limited cognitive abilities, physical challenges, and so on, right? So when we are designing the any type of application, it can be virtual reality, it can be augmented reality, AI applications, we have to be very kind of like paying attention to our target users. So we need to put ourselves into the shoes of the target users. We are not designing for ourselves, we are designing for the elderly people who may have like limited mental limitations, cognitive decline, eye vision, and so on, right? So we should not forget the fact that we are not solely focusing on the back end, which is all about algorithms, the precision, and so on, but we should equally pay attention to the front end part, which is all about user experience, interface design, right? So according to my research, right, most of the elderly people, they have that kind of misconception. Okay, technologies are very challenging, very difficult. Not for us, it is for the younger generation. When I was doing my research in gaming for the elderly, so before our study, most of the elderly people mentioned that, okay, gamings are not for us, games are for the younger generation. But when we design an elderly-friendly games, like, you know, tested and evaluate with our target user groups, like they found that, okay, it's not that bad, we can do it. It can be applicable to the target users, right, the elderly people. So the same thing applies to the AI applications, right? So when it comes to designing and developing AI applications, we should put ourselves, we should empathize our target users, right? So in terms of all inclusiveness, accessibility, and also, like, you know, user friendliness, ease of use, usability, they are all important factors that we should, you know, take into account. Yeah, thanks.
Thank you.
I have to continue on the same theme because we have done some studies and some experiments with the concept of zero UI, which means that you don't have the UI. The results and what you are delivered with should be delivered in a way that you don't use any interfaces, any mobile phones or stuff. Things just happen, so to say. One thing that we are of course taking the first steps in thinking about the digital twins, but our heads are far ahead already, and something that I'm really looking forward to is that when you can see that we are all thinking in our own areas or domains about the digital twins, but how do they play together? I mean, if we have a digital twin of an elderly person, Dr. Janne has about the diabetes or different organs created some digital twins. Optomed is creating data for digital twins. Buildings are already digitalized a lot. So how does all of these digital twins play together? How can we, for example, in our case, place the elderly digital twin into a digital building? How is that cooperation happening? And I think that when we reach that level, we can see even more benefits with the AI and all the digital twins.
So, in my opinion, I think AI definitely will be developed for many years from now. And in terms of theoretical, the scientists will always try to make it better in whatever ways. For example, very less error or very high accuracy. This is the way the scientists will try to develop. But when we are talking about normal people, younger or older, I believe many people will talk about commercialized application of AI. So I give you one example. Today we are talking about aging people. When anyone grows older and older, then they should have some kind of disease in some point of the age. Then the disease developed to some point. Now, the commercialized people will try to create some products for them. I give you an example. The Jewish, with different age, they may develop some disease. Then if the Jewish producer can use AI to apply which kind of Jewish that is appropriate for different disease of different age. Now, if you know which type of Jewish that is appropriate, you produce it and then you sell it, then you gain some money. That's the application of commercialized. So things like this, I believe AI will help, and many people will get a benefit from that in different ways, in different countries. And if you go to Japan now, I believe you know that the aging society in Japan seems to be leader. Aging society means more than 20% of 65 years old. That is the categorized of aging people, aging society, according to the UN. So UNESCO. So I believe the AI application will go in many different ways. And for industry, for example, my student, one of my students, she is sitting there, she developed deep learning. If you have the plastic drawing, her program using deep learning can analyze and give the cost of 3D models in just some seconds. Finish. Just like that. This is the application of industrialized people who can apply the AI. So the scientists like this will always improve the way to do business more and more, and that business will go for industrial, for the healthcare, for many different things like the products focusing on eyes, and then in the future will be some other handheld like this. So I believe AI will have a very good application, and also I also believe that the AI will come personally to us, maybe on mobile phone, maybe on your house, on your car, on your many equipments that we use in recent. So I think we should not afraid of AI. We just have to use it, utilize it. But the fact is sometimes AI can really help and eliminate some jobs. I believe you know that in newspaper now, many of the magazines just disappear just because of the computer can or AI application can help. But it is getting better and better, but not 100% replace the human. I believe human is still the best for realizing, doing, comparing, entertaining, things like this. Okay, so I believe today we have learned a very good knowledge from professor in Finland and many people in Thailand, and including every one of us. So thank you very much for everyone, and we hope to see you again next time.
Thank you.
Okay, thank you very much for all the panelists and of course our moderator. So we have had very interesting discussion with very scientific approach, then approaching for the national screening, what it can be in the personal level, what it can be in the commercialization, and in the interface stages and so on. So this has been amazing discussion, and so this is a start of the series what we are planning to have. So the Thai Finnish alumni series. So we are planning to have similar discussions all around next year from very different topics. So we have already the track to have one about forest-based bioeconomy, which would concern some professors from Kasetsat and some Finnish companies involved. We are also having one track for the music topic, where the local music institute and Finnish Sibelius Academy and Finnish Sound Systems from Genelec will be participating for next year. So just follow the embassies and web page, as well as we have a Thai Finnish alumni group in the Facebook, and so you will get more activities what is coming with us on this year. So thank you so much for all the speakers. We have a small token of appreciation for our moderator and our local panelists here. But after this, we have only friendly discussion, and we are finishing the live streaming. I remind that the the live streaming have been in the Foreign Correspondents Club Facebook page, and you can go anywhere there to watch the video of the last 2 hours. If there was some interesting points you want to go, you can go anytime there to watch the video, so it will stay there, the recording. Thank you very much. Still, hopefully there is maybe some coffee more, and please take, and we have a friendly discussion, and see you later. Thank you.